Hello, good afternoon, good evening, good morning. Welcome to Kina Ed Show. Wow, today's show is going to be something else. We have two heavy specialists on today's show, and we're going to be getting started in a second. By the way, my name is Emmanuel Adegola, and I'm so glad to be co-host of this show today. So I'm going to be asking our guests themselves. So just 30 seconds, introduce yourself, your area of specialty, and just let us know how you feel about this show. Over to you, Dr. Francis. We can start from you today. Dr.
All
Francis.
all right. Hello, ladies and gentlemen. I'm so glad to be in this forum. My name is Dr. Francis Mwafo. I'm a board certified urologist. I have a private practice in Dallas. I've been a urologist since 1997. Um, I was in the U.S. Air Force for 4 years on the rank of major, after which I went into private practice from 2000 and been on that till present. I'm affiliated with multiple hospitals, Baylor Scott and White Hospital, Ennis Regional Hospital, Crescent Medical Center. I'm a general urologist. My practice comprises of mostly prostate issues, both the BPH and prostate cancer, which we're going to tackle today. I also have a very big practice in kidney stones. I do a lot of incontinence for male and female. I do a lot of erectile dysfunctions. I do a lot of vasectomies and a whole host of general urology.
Wow.
Again, thank you very much for having me.
Awesome. That profile is very intimidating, but thank you so much. We are so glad to have you over. Okay, Dr. Agawa, can you go ahead and just introduce yourself to our viewer?
Thank you so much. I'm Dr. Ashwani Agarwal. I'm one of the board certified medical oncologists. And first of all, thank you for having me on this show. I'm truly honored. I didn't know I'll be so popular in Kenya because this is my dream place to go with my next vacation. So I can see I'll be already popular there. And I'm one of the board certified medical oncologists. And I started the practice same year as Dr. Wofer started in 1997. It's very interesting. That's such a coincidence. We didn't even know that we started the same year. I belong to a very large group called Texas Oncology here in Texas. It's all over Texas. In fact, Texas Oncology has become one of the largest groups of oncologists all over the world. We have almost like 500 oncologists, uh, lots of cancer center independent standing. And my general area of specialty is genitourinary cancers. We see lots of kidney cancer, ureteric cancers, then bladder tumors, and obviously prostate cancer. I don't deal with BPH. As soon as I get a patient with BPH, I refer them to Dr. Nofo, who's right here on the this thing, and he's one of my favorite people to talk to about any prostate problems. Thank you
Wow.
again for having me, and I
Wow.
really appreciate.
Wow. You are so welcome. By the way, our viewers, we know that you are out there connected, and just in case we are not getting your comment, it simply means that you have not authorized Facebook to display your comment. So all you need to do is go to StreamYard, www.streamyard.com/Facebook, and it's going to take you less than 5 seconds. All you just need to do is authorize Facebook and StreamYard to be able to sync together for your comment to be able to show. And just in case you have any questions for this specialist, I tell you what, it will take a fortune for you to have just a 30-minute session with them. But they're going to be spending 60 minutes undiluted with you today. So make sure you take advantage of that. I'm going to be bringing in my co-host, Mr. Alex, to also introduce himself and his role with David Omeneko Foundation. Over to you, Mr. Alex.
Yeah. Hello, everyone. I'm so excited to have these heavyweights here with us today. Like I have always said, we are support staff. I'm a support staff to the CEO, a support staff to the workers in Nigeria. And again, I'm going to act as a support staff to these heavyweights here today. Thank you.
Awesome, awesome, awesome. Before, as you know, this is not my show. I'm just a co-host. Okay, so the doctor herself, the elegant celebrity herself, is right on the show with us. She is the host of the show. But before I bring her in, I love to bring her in an elegant way. All right, over to you, Dr. Kida. You are muted.
Hello, everyone, and all our viewers from all over the world. Welcome to the show. We're excited for another episode of Kina Health Show, and today I'm excited to have Dr. Mwafor and Dr. Agarwal with us today. We've been doing a lot of work on cancer, and we wanted to tackle prostate cancer today, and not just prostate cancer, any other male health issue as related to the prostate. So stay tuned, and we are going to give you all the information you need. You all know me. I am a family nurse practitioner. I've been a nurse for over 35 years, and I've been a nurse practitioner, family nurse practitioner for 5 years. Enjoy the show.
Awesome, awesome. Thank you so much. And we also have Dr. Bright with us from all the way from Nigeria. Dr. Bright, can you hear me?
Yeah, good evening, Dr. Emmanuel.
Awesome, good evening. Can you please go ahead and introduce yourself, 30 seconds to our viewer.
Oh, thank you. Bright Ugochukwu is my name. I represent the DOF here in Nigeria, and I'm glad to be on the show. Thank you.
Awesome, awesome. You are so welcome. So I'm going to be stepping aside and then let my co-host, Mr. Alex, and of course the host himself, Dr. Kina, take it over from here. You and our VIP guest, over to you, Mr. Alex.
Yeah, you're all welcome. Like I said, we are taking off with, normally we will want our listeners, our viewers, wherever they are, we want them to understand the topic, and we want to start with explanation. Prostate cancer, what is it? And what is the difference between prostate cancer and prostrate? Dr. Mwafor, we want to start with you.
All right, Mr. Alex, thank you again for inviting me to this wonderful forum. Let's begin by actually talking about what exactly does prostate do in males. All right, prostate is a male gland. All right, and the function of the prostate is to provide nutrition for the sperm so that they can achieve its maximum potential, especially during the reproductive stages. What's happened is that prostate gland is wrapped very close to the bladder neck and also the proximal urethra is wrapped around that area. Usually, before we get into puberty, is a very small gland, a very tiny gland. But what happens as we start getting through puberty, just like females, they start developing breast and other necessary organs, to get ready for puberty. The same thing happens in males. What happens is that the prostate starts growing, especially under the influence of testosterone and the DHT. DHT is an active or potent type of testosterone that really helps, the prostate to start growing at that point. Also, at that time, the prostate, gland, the receptors in the prostate glands, is all ready to go with stimulation from the prostate and DHT. And what happens is that the gland will grow, not only the gland, it also has a component of the stroma, which also start growing also at that point. So that is really what the prostate, that is how it developed. Now, to better understand the different diseases or the differences between benign prostate enlargement or hypertrophy and prostate cancer, is very important for one to also understand the different zones of the prostate. So what happened is that prostate actually has three components one can talk about. It has the peripheral zone, it has the central zone, and it has the periurethral transitional zone. Okay, that's really very important. Now, I'm not sure whether you guys will be able to see on a systemic diagram that I have here, really the different parts of that. This is the peripheral zone, all right, the central zone, and the periurethral zone. Keep that in mind because we're gonna come to that. That will really explain again the different diseases that usually happen, BPH and prostate cancer. So what happened is that as these glands start developing and start enlarging, it start growing and start blocking, choking off this entrance. All right, they start blocking this entrance. And that is really how BPH mostly happens. It's mostly a growth of the periurethral and the central zone. Unlike the prostate cancer, it's mostly prostate cancers are found on the peripheral zone. And when we talk about how we diagnose and how we evaluate patients, that's important, on that aspect. All right. So the effect of the growth of the transitional and the periurethral will cause mechanical obstruction, choking off of that. Also, the dynamic obstruction will also happen. Is mostly the smooth muscles of those prostate will block and cause dynamic changes on the bladder, which are some of the symptoms we get, when somebody start having a BPH issue. And as you get older, you can see that sometimes very common medications that we take for granted, like a nasal decongestants, if we have cold or whatever. If you have prostate issue, you take those, all of a sudden you're having problems with the urination. What's happening is that those receptors, which we're going to talk about here, are very active and they even cause more restrictions on the flow of the urine. All right.
Okay.
Awesome. Thank you so much, Doctor. Don't let us go too much deeper into this so that we don't get lost. I'm beginning to take my pen now to write my note, and I hope Dr. Kina is ready to host our guests today because you will be able to bombard them questions as needed. So I don't know if Dr. Agarwal wants to add with what Dr. Francis has just said. Dr. Agarwal, can you hear me?
Yes, sorry. Yes, go ahead.
Okay, you want to add to what Dr. Nwafo has just said?
Yes, it was a very nice, comprehensive review of the prostate, basically the anatomy and all the zones of prostate. I mean, it reminds me back to my medical school days when we used to try to mug all this up and vomit at the time of the exam. And this was so nicely reviewed in a very simple way. It was very impressive.
Awesome, awesome, awesome. So over to you, Dr. Kina. You are muted.
Dr. Francis, I know as a general urologist, you see these patients every day. They come to you from family care doctors, PCPs, and family care providers. What usually from them to make a referral to you? What are those things that the patient should be looking at for? The signs and symptoms that should make them want to go see a urologist?
Very good question, Dr. Kina. That's a very good question. So, urologists, this is our specialty. We specialize in this. What happens is that mostly a lot of patients, they don't know what's going on. Again, some of these male patients, all of a sudden, they start seeing themselves getting up more often than they used to during the night. All of a sudden, if they're making a trip, they have to stop to the bathroom, looking for a bathroom here and there. Some will blame it is maybe they're drinking a lot of fluid. Some may even blame it, maybe I'm drinking more alcohol than I'm supposed to, or maybe more caffeine, So again, it's more frequency, urgency, stuff like that, that will kind of make them think, maybe something is not right. I should see, they'll come to the primary care doctors complaining of that. In fact, we have a whole questionnaire that even the primary cares, family practice are aware of, i.e., that male patients that start complaining of nocturia, hesitancy, dribbling, frequency, urgency, that's really a sign of prostate issues. Also in this country, we are very used to, doing a PSA at least once a year for the appropriate age. When I say for the appropriate age, it's actually a little more common, both the prostate cancer and BPH in our race. The truth of the matter is that for us blacks, we have a higher incidence of these diseases. So most family practice doctors are known to having a PSA check by the age of 50, on that. The other thing also, a good clinician should also stay tuned with family history. Family history is very important. In Nigeria, we don't, we spend so much time fussing with our siblings, But the truth of the matter is that the family history, if your brother has prostate cancer at an early age, 60, you have three times the risk factor of having that also. So it's very important to know how are my brothers doing? Did he have these issues or something like that? That's again a telltale sign, on that. So mostly we can discover that on PSA. A lot of times it's also the symptoms when they come to the primary care doctors. And of course, a rectal exam. Some primary cares are not comfortable doing a rectal exam, or they think they don't do a good job. But that's what we do. Remember when I gave you the anatomy of the different parts of prostate, the peripheral zone is very notorious for harboring a prostate cancer. And that is why we do this rectal exam. When you put your finger on the rectum, what you are feeling is the peripheral zone. That's what you are really feeling. So a rectal exam is important, for that. So those are some of the reasons why they refer to us. Clinical, symptoms. Sometimes, the PSA is abnormal. Sometimes, they do a rectal exam and they discover something not right. Or even a urinalysis, may even suggest, that he may have urinary tract infections. I should not be having a lot of urinary tract infections, but when they have that, that's a telltale sign that something is wrong with the prostate, and that's how we get our referral.
Awesome, awesome. Before Dr. Kina continues, we have a question from our audience on Facebook. That's from Shripa. He says that this is a question: what diagnostic test do you typically order for both through urinary retention or female incontinence? Any of you can go, but this is a question from our audience, one of our audience right there.
Well, I will go. Dr. Edward will come mostly when we talk about prostate cancer because that is his most focus. So again, the most symptoms that they get, PSA is number one in this country. That's really what makes a lot of primary cares to send to us. But like I told you guys also, the symptoms, what they experience, nocturia especially in males, is also a telltale sign that they need referral, to a urologist, either for PPH or for prostate cancer. But for prostate cancer, it's mostly either a PSA or a digital rectal exam. Maybe Dr. Egwa can put a light on that. Dr. Egwa, most of the patients you see sometimes, I'm pretty sure when we refer those patients to you, they probably would, tell you how their prostate cancer was discovered.
That's true. By the time the patients are referred to me, they already have the diagnosis of prostate cancer. Most of these patients, they come to me now these days at a very, very early stages of diagnosis. And I think most of these patients, they had their PSA tested, like you said, at 50 years of age, which is the screening guideline for PSA. So that is the age when they start testing for PSA. And that is why we are finding more and more prostate cancer in early stages when they are asymptomatic, what we call a stage T1 or T2 stage, even before we feel the prostate cancer by rectal examination. Now, some of the symptoms, like you already mentioned, you can see not only in BPH, you can see also in prostate cancer. One of the things I look for in prostate cancer is if they have hematuria. Any kind of blood in the urine points me a little bit more towards of a prostate cancer, and we do a little bit more detailed analysis for prostate cancer. The test is, like you said, again, and this was very nicely. You went through the anatomy of the prostate, all the zones of the prostate, and where exactly the prostate cancer starts. And like you said, it starts in the periphery, and that is a good thing because rectal exam is one of the most important exams we can do, and it's a very simple test and a very simple exam in which we can still detect very early prostate cancer of the stage of T2 when the lesions are still confined to the prostate, and still these patients are very curable. Once the patient comes to me with the prostate cancer, I do a whole the next workup is we want to stage the prostate cancer, what stage it is, and depending on the stage, we go through the treatment guidelines. Now, the staging is very simple these days. The best scan for prostate cancer staging is a PET scan with oxymum. So oxymum is a marker or a dye that they use for prostate cancer and very specific, and it's very highly sensitive and specific for prostate cancer. So I try to get that PET scan as much as possible. If the PET scan is not available in some parts of the world or even in US, when the insurance companies they deny it, I do a CT scan of the chest, abdomen, pelvis, just to make sure that this lesion has not spread to other parts. And I also do a bone scan because the most common site of metastasis from a prostate cancer are the bones.
Wow.
Again, we all follow these PSAs. And once the staging is done, then we can go over the treatment part maybe later on in the program.
Wow,
But
wow.
the good news is, as long as we can find this up to the stage 3, up to a lesion locally advanced, a very large percentage of these patients are still curable.
Wow, thank you so, so much. We have a representative of David Omeneko Foundation from Nigeria, and sometimes the internet could be an issue. So now that he's live and direct with us, we would like to bring Dr. Bright in to give us a little bit update of what is going on right there with David Omeneko Foundation, with the prostate cancer and everything in Nigeria. But before then, I have a short video clip that we would like to play. Over to you, Dr. Bright.
Thank you, Dr. Emmanuel. Thank you, the panelists and our viewers. I hope you're having a super Sunday. Yeah, the David Omeneko Foundation here in Nigeria, we have embarked a lot on this prostate issue, and that is why the issue of the topic today cannot be overemphasized, and is growing to catch public health, is now growing to be a disease of public health concern, prostate, because of the prevalence rate here in Nigeria. So we will be talking as regards what we face here in most of our medical trips while screening for prostate. Somebody sent in a question saying, it is not for us because I'm a woman, I don't have prostate. But if you are a woman, you don't have prostate by anatomy, you could have a father or a brother or an uncle whom you can celebrate this knowledge with. And that could you could be saving a life, you don't know. So we will have to take the knowledge. First and foremost, let us not waste much time. First and foremost, one of the, in our medical trips we have in Nigeria, we screen not less than 200 men for prostate in each of these local governments. And the funny thing, or the most striking thing is, if you just go and pick, say, 100 men, you want to screen them, you discover that over 50 will be showing signs that could lead to they could lead to further tests like biopsy, you know. So and these people don't know about it, they just came freely and say, come, and you discover such a percentage. That means it is growing here and it's really an issue. One of the challenges we're having is the information level here is low, because when you say prostate, people don't understand what they're talking about. If it is not something they can see when they look at their body, or something they can touch, you say, where is the can I touch it? If you cannot explain, if they are not seeing it and they are not feeling it with their bare hands, you may not really be making much sense when you're telling somebody about prostate. And it is so worrisome that even in the level of people you feel should have this knowledge, automatically they don't have it. And I remember one of the questions in our medical trip we were asking, though that was on colorectal cancer. Somebody was, have you heard of colorectal cancer before? The person said, well, what he has heard is Colorado in the US, that he has never, what is really colorectal cancer? So it sounds funny, but the bottom line here is the information, the awareness is very low, and people don't even understand what you are talking about when you are talking of prostate. So that's why the foundation has embarked on an aggressive awareness campaign exercise as well as screening. The second challenge we also face here is what we call the psychological bias. Here, the orientation here is very different, in the sense that if you're having any issue here as regards your reproductive organ and you're a married man, well, 70% of the married men here, if you're having any issue with their reproductive, you're already sitting on a cake of gunpowder, because here we diagnose diseases from our heart. The women, or the mentality here is that once people see you and they're showing one or two signs, say, ha, I said it. God has vindicated me. He was supposed to be coming home by 4. He's now coming home by 6. Look at, you know. So people do a lot of heart assessment that could throw these patients into what we call emotional grief. A man cannot be so free again to explain to his family what he's passing through without them thinking one thing or the other. You see them, no, I don't want to tell anybody so that they will not, I don't want problem. No, let's just discuss it between us. I don't want problem. You see that if the person has not seen, is not opportune to come into a screening ground, the person will carry that problem and hide it so that he will not have problem with the wife or having problem with the family, because he's presenting symptoms of what can occur naturally in the body, So it's really a major source of concern here. Then thirdly is the what we call traditional medicine practice here. I don't know how government regulates it, but these people, they are doing more harm than good, in the sense that if Mr. Okeke has an issue that made him not to urinate well, which I guess could not be this, and Mr. Okafor is having the same problem, this traditional birth attendant whoops, and if they mix their concoction and possibly Mr. A takes it and by chance he now starts flowing well, any other problem you have is that concussion, and people will keep on taking it, and that's why a problem you should have managed will now graduate into something else, and that becomes a very big issue. You also see people with their faith or their religion that will tell you, no, in our church, we don't take drugs and everything works fine for us. And the person will be degenerating. The person will be, the problem will be going from bad to worse. And the person will tell you, no, that is our faith and that is what we used to do. So these are some of the challenges we have over the medical trips we're having, especially on prostate cancer. And that is why we celebrate with the Union for International Cancer Control every February 4th on what we call the World Cancer Day, a day set aside by the international community to celebrate all forms of cancers, not just prostate. So as part of our activity this year, as we have always done in the past, first of all, before I go into the activities, I would want us to celebrate together that the Union for International Cancer Control has accepted our activity, David Oyedemeneko Foundation's activity this year, and it is on their website. So if you just go into our UICC site map of events and type in David Oyedemeneko, you will see all our activities mapped out for this year. It has been approved and published in their website. So we thank God for that. So every year, as we've always done, as I speak to you, we are almost 70% ready for February 6th. Our flyers, our banners, our t-shirts, everything is now set for us to have a perfect and a wonderful celebration of the World Cancer Day. We start with walkathon, a 5-kilometer walk on that morning, because we believe exercise is a very good tool to solving not just cancer-related issues, but to some very many elements. If you take enough exercise, it has a level, it helps. So we are urging everyone, even if you have not exercised since this year, 2021, you join us on that morning and you will have yourself to score good for. So that is what we start. We start the day with a 5-kilometer walkathon in the morning. And that will be from Dananyam Stadium to Hero Square, live here in Owerri, the Imo State capital. Then after the walk, we will go into what we call workshop or public lecture, because we are into partnership with the Nigerian Cancer Society Imo State branch and other sister cancer organizations that we are approved in the state. So we will go into a workshop and public lecture, especially on testicular cancer, that will be delivered by the oncologist, Dr. Duru Innocent. After the workshop and the lecture, we will now go into screening full time. And this time around, we are just having free screening for mammogram. We are having for prostate. We are having for fecal occult for colorectal cancer. And that is how we want to start the year. And that's how I want to wrap up on the show. Once again, I thank Dr. Emmanuel. I thank the panelists and all the viewers. Do have a super Sunday.
Awesome, awesome. Wow, wow. That was a very good and fantastic report all the way from Nigeria. What a wonderful, wonderful work David Oyedemeneko Foundation is doing. Thank you so much. Over to you, Dr. Kina. We have some questions. Actually, before we continue, sorry for that. We have some questions. I think this will be for Dr. Bright. Maybe you will have to answer that. There's a question right there that says, where can you get the screening in Eastern Nigeria and how much does it cost?
Okay, thank you. On days like days of World Cancer Day, we offer the screenings free of charge. Since October, we've been doing free mammogram at Everite. You call in, then we schedule you. But for that day, we'll be doing it. If you join us at Dan Anyam Stadium, then we schedule you for screening. And that's the foundation doesn't charge any kobo for screening those issues we've been doing. That's how we've been doing it in the past, and I don't think on that day is going to be different.
Awesome, awesome. So as we continue with our conversation, I believe we have another question from Shipra. He says, do you also see increased prevalence rate of ED? I believe this question should go to Dr. Francis or Dr. Gara. Over to you, sir.
Yes, for prostate cancer, I can say, I mean, there is a much higher rate of ED, erectile dysfunction, in these patients, and we try to address it right away. And there are many reasons for it, actually. And one of the main is testosterone is like a fertilizer for prostate cancer. And one of the treatments of prostate cancer, or a medical management of prostate cancer, is we knock down the testosterone levels as much as we can to almost what we call is castrate level, which is like almost a chemical orchiectomy. So we give certain drugs, and that itself causes this erectile dysfunction. And we have a very good specialist in our neighborhood, Dr. Francis Wofer, who is a specialist in ED, and a lot of my patients go to him for help.
Awesome, awesome. Does Dr. Francis wants to add to what Dr. Gar said?
Yes, what Dr. Agwa said is true. That with BPH, prostate cancer, sometimes your rectal function get impaired also, and that's why it's good for you to have treatment, especially for BPH, because as that prostate swells up, it's actually pressing on the nerves on the side of that prostate also. But when you reduce the size for BPH, it helps to relieve some of that pressure on those nerves, and that helps. So that's that's a very good comment that he made also on that. Thank you.
And also, I really want to congratulate Dr. Bright in Nigeria for doing such a wonderful job with the foundation. Honestly, keep up the good work in free screening for all these things is amazing. And the best thing we can do actually for the prostate cancer is the screening, because if we can detect in early stages, this is very curable cancer. Once it goes to late stages to stage 4, then it becomes less and less curable. It can be treated, and we can get them into remission, but it's not curable. But if we can get them with the help of Dr. Bright, get all the screening done and get them early diagnosis, I think we can help a lot of these patients in curing the disease. Thank you, Dr. Bright.
Awesome. Thank you so much. Once again, before I bring back Mr. Alex, my co-host for this show, just in case you are connected with us and maybe possibly you've posted a question, we are not seeing the question, all you have to do, it will take you less than 5 seconds to do. All you have to do is go to www.streamyard.com/Facebook. What it will do is it will enable you to be able to authorize Facebook and StreamYard to communicate together. Also, if you have a suggestion on maybe how to improve on this show, or you have a topic that you would love us to treat, or you have a certain suggestion you would like to give to the host of this show, all you have to do is send your email to kina@drkina.com. drkina@drkina.com. Once again, kina@drkina.com. So as we continue, over to you, Mr. Alex, to introduce the next question.
Yeah, I want to go to the oncologist right away. Could you let us know what are the signs and symptoms you normally look out for when somebody comes to you complaining of prostate? How do you really identify and begin to navigate in the area of cancer? What are the signs and symptoms you normally expect?
So that's a great question for all the clinicians listening to this talk. The main thing these days is most of the prostate cancer are, at least in America, they are diagnosed in the asymptomatic stage. When they have no symptoms, they went for the routine PSA screening and they're able to detect it. Since Dr. Francis, he talked about the zone where this prostate cancer affects or starts in the prostate is the peripheral zone. Most of the time, there are hardly any symptoms, but the main symptoms can be once we have some these patients have some symptoms. They could be hematuria, which is blood in the urine. That is a bad sign. Again, they can have all the other symptoms of benign prostatic hypertrophy, which Dr. Francis alluded to just a minute ago, which include hesitancy, urgency, getting up at night several times at night to pee. So these are some of the early signs of BPH and can be the early signs of prostate cancer. The easiest thing for us as clinicians we can do it when any physician, any male patient visits the physician. Rectal exam is one of the easiest low cost exam that can be done on all these patients, and we can detect still the prostate cancer in very early stages. Now, this is for the early stages. If the prostate cancer progresses to metastatic disease, which means that it has gone beyond the prostate to the bones or other places, then there will be signs and symptoms of where the cancer has metastasized. So, if it has gone to the bones, these patients will start having bony aches and pains. Sometimes they can have even fractures of the vertebral bodies or fractures of other weight bearing bones like femur. And for the first time, we will detect that it was due to the prostate cancer. And if the metastasis has gone to the liver, we'll start seeing some signs in the liver function test that the liver function tests are elevated. If they've gone to the lungs, some of these patients may start complaining of some kind of shortness of breath or chest pain. But the most common these days, what we see in US is asymptomatic patient, their PSA was rising, and the prostate cancer is still in a very early stages and is very curable at this time.
Wow. Wow.
Let me. I'm gonna make a comment on this because actually, as the urologist, we are the ones that start the ball rolling, and get Dr. Egwal also involved, with the diagnosis of prostate cancer. Before I go to that, I also want to again echo with what Dr. Egwal said, to Ugochukwu on your effort in Nigeria in terms of, the screening for prostate cancer, and also word of encouragement, because the truth of the matter, like I said, is that prostate cancer, is the second most common cancer death in males, especially Black males. So one of the things that I would like you to tell on your education to my fellow Nigerians, on your education is, number one, almost 350,000 people will be diagnosed with prostate cancer every year. It's very common. Also, you should tell them that is 50% of those that are diagnosed are Blacks. But prostate cancer is a Black man's disease, just like high blood pressure is. So that should also, gear you guys up more towards the screening, just like you do colorectal. Prostate should be high up there, higher than testicular cancer, because it's very common in our race. And also, like Dr. Egwal said, if we catch it early, you can be cured. That's another good news about it. But anyway, like he said also on the how do we really, diagnose, prostate cancer? Like I said, the PSA, the rectal exam. So if any of those are abnormal, then what we tell patients is that you need a prostate biopsy. And I saw one of the comments, that one of the audience, asks, how do we do a prostate biopsy? All right. Still in this country, we still do the transrectal ultrasound approach. That does have some problems. Slowly, some of us are moving into the perineal approach. The difference is just sometimes, the infection, post-op infection rate is a little bit, less with transperineal. But again, transrectal, we have done so many, for so many years, and in good hands, infection, post-op infection rate is under 1%. How do I do that? How I do, and I do a lot of them in my practice, okay? What I usually do is, number one, you give them a prescription for an oral antibiotics and a prescription for an IM injection. You will tell them to start the oral antibiotics 2 days before the procedure. That's number one. Number two, also will give them a kit or a prescription for a prep, where they do an enema to clean the rectum, the day before and also the morning of the procedure. So when they bring that IM in medication, when they come to the office before you start the biopsy, you give them that IM injection. And so far, it has worked. My infection rate is way under 1%, but it can happen, on that. Perineal approach is, another technique that we're slowly moving, towards that. The infection rate is a little bit less than 1%, but that's how we diagnose. So PSA or rectal exam, if either one is abnormal, the next thing we do is a prostate biopsy. We also use ultrasound guided, in my practice. Sometimes, there's some areas that use combination of MRI and ultrasound combined. On that, we reserve those for people that you've done biopsy a few times and it's negative. PSA still keep going up. And what we do, we use that combination of the MRI and ultrasound to see. Remember, I told you that more than 70% happens on the peripheral zone. Sometimes you have about 5% that may happen up in this. These are more deep, MRI kind of helps us to see whether there are some lesions, that we probably not seen with the ultrasound. So that's a new technology that also that we're using to increase, our capability to, diagnose, prostate cancer. So once we know, we do that biopsy and we send it off to the pathologist. That's another deficiency, unfortunately, in Nigeria, that also, Dr. Buchukwu, you all have to do in collaboration, with pathologists to look at this. Urologists will get the tissue, then we send it to the pathologist, they look at it, and they come up with is there cancer or not? That's the first question. Is there cancer or not? We usually do like 12 core biopsies. Sometimes I do get some referrals from Nigeria that they probably only did 2 biopsies. Probably that's not adequate. You need more than that, on your biopsies.
Wow.
So if there is, prostate cancer, now we go another important key factor to know is the Gleason score. That's very important. All right, because that Gleason score is, they look at it and they give it a grade of, how aggressive the prostate cancer is. So once we get all that information, then, we'll share that with the Dr. Egwo, and we'll come up with a plan. That's how we'll practice here. Thank you.
Awesome. Over to you, Dr. Kina. I noticed you wanted to say something, but you admitted that.
Yeah. Yes, I wanted to address one of the questions that came through the Facebook.
about where can one get the test done in the eastern part of Nigeria. Like Bright clearly stated earlier, one of the greatest challenges we face back in Nigeria is lack of education, lack of awareness. People don't even know what prostate is, let alone prostate cancer, and trying to find where to go get a test. And most the medical practice in Nigeria is very, very different. So we lay emphasis on educating people back in churches and communities, and empower them to, whenever they go to the doctor, they can ask for this test. But generally, there are some laboratories in Nigeria that you can just walk in, and they usually have like doctors standby that could order those tests. So in addition to Davido Medical Foundation providing free prostate cancer screening during our medical outreaches, there are also several other laboratories where people can get those tests done. So it's just educating people, empowering them, increasing their knowledge and awareness about these types of diseases, so that they can know where to go, when to go, and how to go. So I just wanted to answer Dr. Chioma Usam, who had asked that question earlier.
Okay, thank you so much. There's another question about how do we volunteer in Nigeria. Please, can you share your contact? I believe this question is to Dr. Bright, but he's no longer with us right now. So you want to go ahead and answer that?
Yes. So we do have activities throughout the year in Nigeria, but once a year, particularly during December time, we do go on a bigger medical mission, and many people do travel from the US. So if you reach me, or you can contact us through www.davidomedicalfoundation.org, or you can personally call me or find me on Facebook, and we can give you more information on how you can volunteer for the foundation.
Awesome, awesome. And I believe we also have a question for Dr. Francis. It says, I heard that digital rectal exam can cause abnormalities to PSA level if done first. Is that correct?
That's partially correct. Yeah, that's partially correct. So I would tell you though that the incident is low, but that's partially correct, especially if that person have an infection of the prostate, what we call a acute prostatitis. A digital rectal exam, can make that, a little bit abnormal. So sometimes in that case, a patient is concerned, okay, my PSA is high. Maybe it was because, my primary care doctor did a rectal exam. What I usually tell them is, okay, let's just wait, 2 weeks, go and get another PSA, and we'll see what it shows. Most of the time, you will see that if the PSA is truly abnormal, it will be abnormal also at that time. But yes, answer to that question, sometimes, especially prostatitis, rectal exam may cause abnormal PSA. Also, right after sex, PSA may be a little bit abnormal. But again, just waiting a week or so and repeating that, you'll be able to know for sure.
Awesome.
I have a follow-up question for Dr. Nwafo on the PSA level. Does every high PSA mean prostate cancer?
No, Dr. Kina, every abnormal PSA does not mean prostate cancer. In fact, that's the reason why we do the second thing, which is the prostate biopsy. Because it's not only prostate cancer that causes PSA to be abnormal. Big prostate, which is a benign disease, prostate infection, like I told you, prostatitis can make PSA abnormal. Of course, prostate cancer. So sometimes, some guys come to my office, because they refer for high PSA, they're all anxious and whatever. And I usually tell them, one thing we do know, number one, is only prostate that makes PSA. That's number one. The other thing that we do know is that PSA is not prostate cancer. Those are two different things, and that is why we need to do the prostate biopsy.
Awesome, awesome. Thank you so much. I just want to beg all our viewers, this information is very, very loaded. And I think you should save a life by just sharing this video, okay? After we have this, after we finish with this show, this video also is going to be uploaded to Dr. Kina's YouTube channel. That's to be at the YouTube channel. All you have to just look for, search for Dr. Kina, is going to be there. So it doesn't cost you anything. If Dr. Agora, if Dr. Francis could volunteer themselves, volunteer their time, I mean, you all know how much doctors get paid, okay? So if they could just volunteer their time, I mean, David Obeneko Foundation is not paying them. Dr. Kina is not paying them. They are doing this for you for free. So you could just do it. It's just a click of a mouse. Share this video with somebody. Somebody will watch this show and you don't know whom you might be saving. Okay, I just think I should put that out there. I know our time is fast spent, but we still have a lot to cover. Mr. Alex, you want to look into the questions that possibly we've not covered and see anyone we could just cover within the next 4 minutes? You are muted.
Treatment. So there are so many things, but it is important that we've been, because of a number of questions and the type of questions that have been coming, occasionally we entered into stages and the treatment, but it is good for us to know what are the stages of prostate cancer. Let us know it formally and perhaps resolve the rest of the question for the second edition of this program. Let me go to the oncologist right away.
Okay, so who is going first? You can unmute yourself. You can both unmute yourself. Okay.
Yes, this is Dr. Agarwal again. Thanks for this question. Prostate cancer, it's basically, the staging is what we call is a TNM staging. T stands for tumor size, N is for lymph node metastasis, and M is for metastasis to the other parts of the body other than locally, other than the prostate or beyond the pelvis. So T stages is again divided into 4 stages, just on a very 50,000 view, 50,000 feet view of the staging. Stage 1 T1 is limited to the prostate, and most of the time it is diagnosed by rising PSA, and then they undergo the biopsy, and then there are sub stages of T1. The T2 is a little bit more advanced when we can start feeling the prostate, but it is still limited to the prostate gland. The T3 stage, it has infiltrated into the local tissues, including the seminal vesicles around it and some local rectal areas. Thus, the T3 and T4 is a more advanced infiltration of this prostate cancer way beyond the prostate into the local tissues in the pelvis. So this is the T staging from a very high 50,000 feet. Then there are sub-stages of T1, T2, T3, and T4, which is more for our oncologists and or our urologists to know, that because that will guide our treatment principles. And then the second stage is the lymph node metastasis. N0 is no lymph node metastasis, and N1 is when there are lymph nodes involved in the local area. And then the metastasis M0 and M1 is M0 is no metastasis to the bones or liver or lungs or any other organ other than in the pelvis, and M1 is metastasis to any of these organs. So this is a T1, T2, TNM staging for prostate cancer, and it is important because this is what guides the prognosis of the patient and also the treatment of the patient. And like I said, if we can detect the tumor up to even locally advanced T3, T4 disease in early stages, a large percentage of these patients can be cured. And again, one more thing I want to make sure that The prostate cancer, when we diagnose in 50s and 60s in young patients, is a totally different disease as compared to the one we diagnose if the patient has prostate cancer in their 70s and 80s. The patients who have prostate cancer in their 70s and 80s is a very slow growing process, and it's a very kind of a benign disease still. Whereas the one who get in 50s and 60s, it's a very aggressive cancer. And most of the patients, they end up, if they don't, are not taken care of at the right time with the right treatment, they end up dying of prostate cancer. So these are the patients we pay very high particular attention, and we are very aggressive in treating these patients with all kinds of treatment to start with, so that we can salvage most of these patients in early stages.
Awesome, awesome. Thank you so much, Dr. Agua. We have I know our time is fast spent, but we have two questions that within the next 1 minute, if we could just quickly give them just the straight answer. So the first one says, what is the survival rate for prostate cancer in the US? And I guess the second one says, Dr. Agua, is radiation ever recommended as an initial option or typically prostatectomy? So you have those two questions. We have just less than 1 minute to answer that.
Okay, I'll take the second one. The first one is a more loaded question because the prognosis depends on the stages of the cancer. So that takes another 1 hour of thing. Uh, if you can detect, again, like I said, in the early stages, you have a very high chance you can cure it. If it's metastatic disease, depending on whether you're diagnosed in your 50s and 60s versus in 80s, you can live for just 5 years versus you can live for 20 years, depending on when you're diagnosed in the ages. But as far as the radiation is, um, here I have a little bit of bias, I must say. I think radiation for early stage prostate cancer is becoming more of a standard of care as compared to surgery. And there are several reasons, and there are several ways of doing this radiation. And one of the radiations, we have this in Dallas, luckily, is called proton therapy. And according to these people at proton therapy, the the lowest they have the lowest complication rate of any treatment in prostate cancer. It's very expensive. A lot of time insurance companies don't approve it, but they say they have the lowest complication, and Dr. Wofer may shed some more light on that. But two main complications with the prostate cancer treatment is two. One is incontinence, and the other thing is erectile dysfunction. And these are the two main problems we encounter. And now there are surgeries that they can do, which are called nerve sparing surgeries, and they can still uh, take care of some of the erectile dysfunction. But most of these patients are never what we call is trampoline dry. They always have a little bit of incontinence. What they've done with the radiation, I think that incontinence, which is becomes a very, it becomes uh, very, it's a bad complication. Just you're leaking all the time. I mean, that is a terrible complication for men to handle. So that, I think, rate is much lower with the radiation. Sorry, it was a
Awesome.
long-winded answer to a short question.
It's okay. Thank you so much. Dr. Francis, you want to add to what you said?
Yes, just like Dr. Agua, said, for what we call, so prostate cancer can be classified under one bucket. One, localized prostate cancer, or not. That's important. So it depends again, if you've done all your workup, everything looks contained. The other thing also we looked at also the grade of that tumor, the Gleason score. That's also very important. And like Dr. Egor said, especially if they have high, Gleason score, 4+4 or 4+5, you know, sometimes when we do surgery, radical prostatectomy, which I still do, on that, the problem with those high Gleason score is that usually the margins will be positive. We end up referring them back to radiation guys. That's why he said, if you listen to him carefully, radiation is becoming, more of a standard of care, especially on those higher Gleason score. However, on some of the ones that have Gleason 3+4, on their specimen on the initial biopsy, and maybe not as multifocal, maybe 12, or not all the 12 cores are all positive. Let's say you have about 3 or 4 cores out of 12, positive. One can still make a very strong argument, of doing a radical prostatectomy. Because, the good thing about radical prostatectomy, if the margins are all negative, everything is contained, again, those people are cured. He's right, sometimes complications, of incontinence or erectile dysfunction, can happen, is a little higher than radiation. However, with our nerve sparing techniques, we have been doing a good job. The problem also, just like surgery with radiation, sometimes I've seen patients, who may be perfect candidate for surgery, but you send them to radiation. Radiation do have their own problems too, The incontinence can be very stubborn. Urethral stricture can also be a problem, on that, So that's why we work with them. We work with oncologists, to put our heads together and come up with, the best therapy. It's not a one size fit all for everybody, It depends, on the age. It depends on the Gleason score of that cancer. It depends on the PSA. We put a lot of things together to come up with the therapy. But the two standard of care for localized is surgery or radiation. Sometimes they may need both, on that. And, studies have been done, comparing them 15 years out, the efficacy is the same.
Awesome.
That's
Wow.
that's
Wow.
so true. I agree totally with Dr. Francis about this. It's not one size fit all, and this just the treatment of prostate cancer is a full 1 hour lecture itself. So I was just summarizing in a one line, which was a terrible thing to do.
Wow. Wow. Well, thank you so much. I mean, I know our time is way fast spent, but just in case someone wants to locate you, you want to share your, how can our audience, in case someone lives in, let's say, Dallas Metroplex, or even maybe outside of the country, someone might want to connect with you. So how can they locate you? Let me start from Dr. Agarwal.
Yes, you can connect with me with on my email ash1ash number 1 dfw at gmail.com. You can call me anytime on my cell phone 469-877-8483. And I get all these calls from India a lot, from all over, actually all over the world for this thing. And there is no charge for this. I just like to help people. I don't know if I can provide much, but I can give my best opinion in most of these things as a second opinion or third opinion. So please feel free to email me anytime. ash1dfw at gmail.com.
Awesome. And we will try, we will get that also over to you guys, and we will get it actually ready before the next episode, because I have a feeling that we have not done enough justice to this topic. So watch out for part 2 of this show. So over to you, Dr. Francis.
Again, Dr. Kina, thank you for this forum. This is very important for our community, both here in the US and especially also in Nigeria. But my practice, is my address is 20 Northgate Drive in Waxahachie, Texas. My email is f14@gmail.com. Our phone number is 214-980-1920. You can call us anytime. Come visit our practice, come visit our office. You can email us. We do, give consults, even to people in Nigeria also, especially with the Zoom, things are much easier, to do that. You have a question or anything like that. And again, thank you, Dr. Egwa, for coming in so that they can see the spectrum. That's why I refer my patients when they need radiation, they need chemo and stuff like that. And I've known him for a very long time. Fine medical oncologists, we all work, together. Like he said, they have a very big, practice. We have everything here that we can share with you. And again, Dr. Kina, thank you. This need to also especially in our community in Dallas, still a lot of our folks are not going to the doctors, for PSAs, there's no excuse, for that or screening or stuff like that, Our Nigerian Physician Association, we have every specialty you can think of. Dr. Kina has been very helpful on sponsoring a lot of these programs, getting involved with our community. I guess, it's education, share this video, and we're here to help.
Awesome. Thank you so much, Dr. Nwafor. We really appreciate you. Before I bring back the host of the show, let me bring in my co-host, Mr. Alex, for his closing remark and possibly one or two tips that he is going home with today.
Well, it has been a very heavily loaded program with a lot of information. But what I think everybody needs to do is they have emphasized on the need for early screening, because they say if you get screened early, there is a wonderful chance that you are going to survive. So as soon as you get any symptoms, you make sure you go for early screening and then do the annual screening, and then make sure that you take regular exercise. Thank you.
Awesome. So before I bring back the host, Dr. Kina Omeneko herself, so we have the intro. Over to you, Dr. Kina.
Wow, what a show. I'm so grateful to Dr. Nwafor and Dr. Agarwal for bringing us a wealth of information. And we had a list of questions that we were going to ask them, but we didn't even scratch it. So I'm going to confess that and ask your request that we'll have this show the next 2 weeks so that we can complete. We have a wonderful number of my colleagues, nurse practitioners. They're all logged in. Everybody's listening. It's very informative for most primary care providers. This topic is something that we really need to continue to discuss, especially in our community. We can say enough how important it is for men and women to visit your primary care physician annually and get screenings done. Most doctors, from what I've seen, they do PSAs from age 40, so which is very good. If the insurance will pay for it, just go ahead and get it done. So we would like for this conversation to continue, if you don't mind. And I thank our audience from all over the world, everybody that's logged in. This is a great show, and we want to continue to bring you this information that is very critical for your well-being. You can reach us anytime. You can reach me through davidomenokoro.org or drkina.com or crystalfamilyclinic.com in Mesquite, and we take care of you. I want to thank the panelists, the audience, our viewers, and Dr. Emmanuel and Mr. Alex for another wonderful show. Thank you.
Thanks, Dr. Kenya. Thanks for having us.
And to all our viewers, once again, thank you so much. I see Pascal, Josie, Chioma, all of you. Thank you so much. This is Emmanuel Adigbola signing out, and see you next 2 weeks.